Thank you very much for that introduction, Professor Tai, and thank you for the organizers for providing access to this discussion. So, what I will do is cover the overview of tacrolimus over 30 years, mainly focusing on the pharmacokinetics and pharmacodynamics of tacrolimus. This is a disclaimer slide. We all know that end-stage disease is a major cause of morbidity and mortality and associated with significant healthcare costs. Just in kidney transplantation, if you look at it, then compared to patients remaining on dialysis, the mortality rate is 55% lower with transplantation compared to patients remaining on dialysis. And if we then calculate the cost over a 10-year period, each transplanted patient saves approximately 380,000 euros per year over that period of time. So, what it means is that we have got effective treatment and cost benefit associated, but we need to maintain immunosuppression to get best graft function over time. Now, immunosuppressive therapy has evolved over time. Now, let's look at that how that helps. So, as Winston Churchill said, the longer you look back, the further you can look forward. If I look at when I started in transplantation around 1975, we didn't have cyclosporine in those days. So we only had azathioprine, which was discovered in 1960s, and then ATG, which was used together with azathioprine and prednisolone. The first major breakthrough came with cyclosporine around 1980s, and thereafter that was the tablet formulation, and then after that we got the cyclosporine microemulsion, which was an upgrade because it improved the absorption kinetics of cyclosporine. Tacrolimus came soon after, was launched in 93, we'll discuss that. And then you also have this tacrolimus, which is prolonged release formulation, which is an upgrade from the immediate release formulation. And as we go along, we tend to see newer and newer understanding of the drug. Now, what has happened over that period of time is we have reduced the rejection rate and increased the 1-year graft survival to approximately 80 to 90%. But where are we? Are we actually transplanting for 1 year, or are we transplanting for life? So if we start looking at long term, what about survival, and where does tacrolimus fit in? So what I'll do is cover the history of tacrolimus, look at the pharmacokinetic pharmacodynamics, look at why it is called narrow therapy index agent, and then how do we manage different formulations of tacrolimus. So discovery of tacrolimus was discovered in Japan. In 1982, we started a program of screening many of the fungal species, specifically to look at interleukin-2 inhibitors. Okay, and that led to the discovery in 84 of tacrolimus. We called it FK506, and it was isolated from Streptomyces tuberculosis. And the red dot is where Tsukuba is. It's a mountain. And this is where the facilities are. Now, what we realized that it was more than 10 to 100 times potent compared to cyclosporine. And then the name comes from Tsukuba macrolide immunosuppressant. The tacrolimus stands for that. And the brand name for the tacrolimus at that time was ProGraph, which meant supporting or protecting graft. The first clinical experience actually happened in University of Pittsburgh with Professor Starzl. Now, they had a 26-year-old patient on her third liver transplant was maximized dose of cyclosporine because it was giving her significant nephrotoxicity. So they decided what to do with her because you cannot have the third severe rejection. So he added tacrolimus. It was not ProGraph at that time, it was just powder, to the cyclosporine. And then 3 days later, the patient had returned to dialysis because of the severe interaction between tacrolimus and cyclosporine. But he realized that he should take out something. So what he did was he actually took out cyclosporine, not tacrolimus, okay, and kept the patient tacrolimus. And then the patient recovered fully and then completely reversed the rejection. And that was then published in the New York Times and ended up in the history. So what you have is you have the marketing authorization, which was then 1993. So 4 years later, we were able to launch the product as a product. Now, if you look at cyclosporine and tacrolimus, there are two completely different structures. The left-hand side is cyclic peptide. On the right-hand side is a macrolide. So, but both of these are virtually insoluble in water. So therefore, each one of them has to be formulated. So what happened with the cyclosporine was it ended up from tablet to neoral formulation, which is microemulsion. And then on the right-hand side, you had to make a solid dispersible formulation which allowed the absorption to take place. Now, in terms of products available in the Vietnamese market, we have the tacrolimus immediate release at 0.5 and 1 milligram, and prolonged release, which is 0.5 and 10 and 5. Whereas the marketing authorization for the immediate release was based on superiority to cyclosporine, and that for prolonged release was comparison of compared to the immediate release formulation over a 6-month period. So again, what about long term? Now, following the initial approval, a large program of work was done. This was in Europe and a similar package in the United States, and it actually represents a research in more than 10,000 patients. Okay, this is kidney, and similar data exists for Prograf as well, for lung transplant as well. The key study here is highlighted, the first key study, which compared the tacrolimus with the microemulsion formulation of cyclosporine. And then this was a 6-month data. What you saw was that you had a significant reduction compared over a 6-month period. And the green boxes there show you that you had lower conversion. So more patients were switched from cyclosporine to tacrolimus-based therapy. Okay? And that was mainly for efficacy reasons. But if you then look at a 7-year, same patients were followed up for 7 years, now you begin to see the difference. Okay? What you see is that the composite endpoint, the graft loss, patient loss, etc., was significantly lower with tacrolimus-based therapy compared to the microemulsion cyclosporine. And same data set goes through at each of the parameters you look at, CNR, toxicity, etc. All of them were lower with tacrolimus compared to cyclosporine-based therapy. This was also the case in an independent study done by at King's College, and this was by John O'Grady, where over a 3-year period they saw that the total survival, including mortality, was lower with tacrolimus compared to cyclosporine. These are the two major studies which changed the clinical practice. What happened was, if you look today, that 95% of the population, transplant population, receives a tacrolimus-based therapy. Right. But what you also see is that the MMF combination with tacrolimus accounts for approximately 60% of the population, and then another 25% who are requiring tacrolimus, MMF alone. Okay, so if you add those two together, the combination is about 90%. So again, what affects long-term survival? Now, in order to understand long-term survival, we need to understand the genotypes. Okay. Now, what you see on the left-hand side is you have the genome, the genes, and you have blood drug targets and drug transporters. The effect on the left-hand side applying to the drug target is called pharmacodynamics. On the right-hand side are metabolizing enzymes and drug transporters, and how they interfere with drugs forms the pharmacokinetics. And the combination of the two leads to the variability in drug exposure. Not everybody has the same exposure from the same dose. And that's the understanding we need in order to understand that. So, if we then look at simple kinetics, on the left-hand side, what is known as drug itself. So the intrinsic kinetics. So the half-life of tacrolimus doesn't change, the volume of distribution, that remains the same. What you can change is the right-hand side, which is formulation dependent. How quickly is absorbed? How long does it take? What about the Cmax? What about time to Cmax? The oral bio, all of those parameters on the right can be formulation dependent. On the left, they cannot be. Okay? Oh yeah. So what you see here on the left-hand side is the Cmax, and this is the AUC. The total area under the curve is what is known as amount of drug in the exposure. So, if we then start looking at what happens inside, you have this is a drug gets into the blood. The drug is bound to the blood cells, erythrocytes, to hematocrit. Then you have the plasma protein binding, and then the amount of drug in the body, which is also bound. So, at steady state, 90% of the drug is in the tissue. Now, tacrolimus is affected by hematocrit and albumin. So, if those go low, clearance goes up, and you need to increase the dose. But be careful, when you have patients with low hematocrit and low albumin, toxicity is higher in those patient population, simply because the binding changes. Okay? Similarly, the effect of corticosteroids. When we add corticosteroids, the dose of tacrolimus has to be increased in order to in order to maintain the same target level. Steroids decrease tacrolimus levels. And then if we start looking at how long it takes, the elimination half-life of about 1 day, which means that if you change a dose, it takes 3 to 4 days. Don't bother looking at the level again within the next day. So about 3 to 4 days to reach steady state. Okay. Now, the efficacy driver, we found in the study which was done, was related to the AUC. So what you see on the dotted line is that you need an AUC of about 150 nanogram hour per mil. Okay. In this study, the MMF combination did not add to the efficacy. However, a subsequent study, okay. So when we look at this, it means that you need to optimize the tacrolimus therapy based on AUC, not on trough level. But we'll come to that. This was further validated by a group in Belgium, Dirk Kuiper's group, and they found exactly the same analysis, that 150 is the cutoff point in 2 different independent studies. You have the same value. What we also found was that in those patients who have over-immunosuppression, the AUC was about 15 to 20% higher. So the margin of safety for tacrolimus is very low. Okay? So you're looking at, that's what I mean by narrow therapeutic index agent. Okay, so you have a safety margin of approximately 25%. Okay, so those numbers are there. Now, how did he find out over immunosuppression? This was related to development of CMV disease, herpes virus. So all those things are listed at the bottom there. Now, what does it mean? It means that for over immunosuppression, you have a price to pay, and the price is management of the disease, of the infections. Okay? Under immunosuppression, the price is management of rejection. So you get, this is the tolerance between the 2 narrow margins. Okay, so how do we manage? As I mentioned earlier, it is AUC. Now on the right-hand side, you see that in order to manage AUC, you have to look at a surrogate marker. And the surrogate marker we use is trough level. So in the blue line in the middle, you have a brand drug. You have a generic high and generic low. So some drugs absorb faster, some drugs absorb slower formulations. Now, if you're targeting 10 nanogram per mil or 15 nanogram per mil, then the AUC associated with each of them is different. And you will not see that AUC simply because you're assuming that the same target level for a different formulation will achieve the same exposure. And that is not true. We'll look at that data. And on the left-hand side, bottom panel here, you see that this is the therapeutic range. Okay, very narrow. Okay, in the sense that this is the safety margin that we're looking at. Now, how do we define? So there are different ways of defining narrow therapeutic drugs. One is European Medicine Agency different definition, which is that significant clinical risk even when bioequivalence criteria are met, very steep concentration profile curve, monitoring of drugs is mandatory. For example, warfarin, we use prothrombin time, etc., and serious consequences of exposures too high or too low. And a similar health definition from Health Canada as well. Now, these are the drugs at the bottom which form the what is known as NTI list. About 8 or 9 drugs. And 2 of them there are cyclosporine and tacrolimus. Okay, so many of the products which are out there, different formulations, are approved on the basis of bioequivalence. Now, please remember, bioequivalence does not mean therapeutic equivalence. What it is saying is, bioequivalence says that the mean exposure in the population is the same or not. It doesn't mean individual exposure, it's mean exposure. So if you look at two formulations that are considered bioequivalent, if the ratio of the mean for AUC and for trough and for and the Cmax is within what is known as the confidence interval. This is like analysis of variance, and it's quite easy to do. Okay? So basically, what we do is that you say, okay, the has to be within the 20% margin. So it comes with 80 minus 20 to plus 25, which is 80 to 125. That's where the original maths came from. For drugs like tacrolimus, cyclosporin, and warfarin, the new definition is reduced. So it is 90 to 111 and 80 to 125 for Cmax. So the AUC has to be within that range. Okay. Now, as I said, it doesn't mean every patient is. Now, this is the real data from a drug, from a branded versus generic formulation which was approved. And you can see the individual values. On the top hand side, liver, the bottom is kidney. You see that up to 50% variation in trough level in 30% of the population, which means that the recommended is that you need to monitor after you convert the patient, and that monitoring cost has to be included in any cost analysis we make. Now, this is an example of another product which is approved, come from Norway, and Ida Robertson's paper. And what she did was she looked at elderly population. This is a bioequivalent product, but not in patients. And if you look at those values there, you see that the exposure to the AUC is about 17% higher, but the trough level is the same. So when you convert, you have the same trough level, but not the AUC, which means those patients, elderly patients, are increased risk of developing CMV infections for that formulation. Okay. Now we see the same thing now more recently from the United States. They have withdrawn the approval characteristics for a product which is already generic and approved in the United States. What was found was that that formulation was crystallizing over time within the capsule. Okay, and as it changed the structure, it also changed the bioavailability. And you see that on the left-hand panel here, this is the bioavailability. And this is the steady state evaluation. So the drug completely changed. So this has now been, FDA removed that from a substitutable list. Now, which means that it leads to a difference in guidelines in the prescribing information in Europe. It is clearly stated that it should not be it should be monitored and switching by the physician, and following any conversion, it was mandatory to form monitoring to maintain the same exposure. Same thing applies to Health Canada. Okay, they've even gone further to say professionals must be advised to consider automated computer. So in the sense that, for example, in the UK, when you, as a GP, when you type in tacrolimus or to prescribe, you cannot prescribe tacrolimus. You must prescribe the brand the patient is on. It doesn't matter if it is a generic brand, but it must be the same brand. So it's branded prescription rather than generic prescription. Okay? Now, this is another data from the product which is approved and is available here. This is published by Minotaur. Nice study comparing over a period of time, over 6 months, number of patients who were started on reference tacrolimus compared to generic tacrolimus, and they were switched over at a certain time point to different formulation. So you end up with, start with about 63 in each group, you end up with about 27 to 63 later. If you then look at the profiles, which was done at different times, you see that here, there's a different in exposure. Okay? And this is at steady state, and this is day one, first profile. But what is also important is the relationship on the far side. You can see that the graphs are not superimposed, which means that you have got, for the same trough level, different exposure for different drugs. Okay? Now, on the bottom, you can see that day 10 and month 6, you have the exposure in terms of bioequivalent differences are not within the guidelines. Now, same thing happens in 6 months and 9 months. You have the same picture repeated over and over again. So, in the sense that no matter where you are, you're still having the same difference in exposure. The impact is that you have got less acute biopsy-confirmed acute rejection overall, but it does not reach significance, and then you also have the patient survival. Now, this is 6-month data. We need to see what happens with this drug over a 10-year period. Hopefully, there will somebody collect the data. And you also see that under steady-state conditions. You see, this is dose normalized. So essentially what they're doing is taking the exposure, correcting for dose, and saying, if the patient was to take 1 milligram of each, what will be the exposure? So, and that's why you see that even on dose normalized, the value is different. You do not have the same exposure per unit milligram dose. Okay, now, the only study where I have really seen concrete data was coming from Haukatal in New Orleans, where the hospital policy was that all new patients would start on the generic this is marketed generic, which meets the European criteria. And so what they looked at what happens to those patients. Now what you see here is that the number of dose adjustments for generics were significantly higher than those for brand. Variability was significantly higher at month 3 and month 6 for generic compared to brand. And it led to increase in antibody-mediated rejection of 12% higher compared to 4 times higher. Okay. Now, did it save money? Well, they say the pharmacy saved $18,000, but the hospital lost $680,000. So in sense, you saved the pharmacy cost, but the hospital cost went up. Okay? Now, let's look at the challenges in the long term. So basically what we see is the long-term survival is an issue. It has changed between 2000 and post-2000. And if you look at deceased donor kidney transplant, 5-year survival is about 80%. Okay? But what is one of the major causes of graft loss? And that is variability of exposure. Because patients don't have consistent exposure, it leads to variability. On the left-hand side, you see the whole population, 6,000 patients followed up in this study, one of the biggest studies I've seen. And you look at the graft survival. As the variability goes higher, the graft survival decreases, patient gets adjusted, and the patient survival also decreases. So variability is a big issue. And there are a number of factors which lead to variability. But before I explain what it means, how do you look for it? The way to look for it is to look at the charts. So you have a chart of the patient on the top and the bottom, the green and the red. So you have the same milligram dose over 6 months, but look at their trough levels. And then what you can do is you can use your phone and put in those numbers and calculate the standard deviation. And you can give you, so the margin you're looking at is around 30%. You have high variability. Below 30%, you have less variability. Okay? So, this is the data. What happens is that if you start looking at the patients who are more variable, they actually have more DSA formation. And because they have more DSA formation, they lose their grafts quicker. Okay? So the variability plays a major role, and that's the reason for the survival benefit. And what are the factors associated? There is genetic polymorphism. I'm not going to cover that today because it's a subject for another meeting. You have non-adherence, which plays a small role. Non-adherence per se is not a big driver of variability, but it is a factor. Drug formulations are very important. The type of formulation you have will lead to variability as well. And the uncontrolled substitution between formulations. So if you have formulations where you change from one to the other, you increase the risk. And here's the data for that. And this comes from my ex-colleague in the US, where you cannot only do this study in the United States, because in the United States, each patient's prescription can be followed up on the pharmacy. So for 15 years, you can follow up exactly what was prescribed so many time ago. So this is the only set I know that exists in terms of looking at the data. So if you then look at the top part, which is that they are the patients who remain with the brand for all the time, and then the bottom one is the patients who were switched, and they were given the cheaper formulation every time they came in for prescription refill. Okay, and then what you do is you look at around 305 patients' data. Now, what do we see? We saw that the dose-to-trough ratio was more variable in variable tacrolimus formulation compared to branded, one side. More trough level measurements were needed to be done, and values outside the 20% margin of variability were higher in the non-branded group compared to the branded group. Okay? So again, you need to start thinking that this is the variability which adds to the cost. So, in summary, what we've discussed today is tacrolimus is a main component of immunosuppressive therapy, about 95% today. It's a narrow therapeutic index medication. Now, there are various formulations. It is not an issue. I'm not recommending not to use anything. What I'm saying is, if we use, please consider the consequences of exposure. Do you have the same exposure for the same trough level? And if not, then you need to probably do AUC monitoring. Intrapatient variability leading to many factors, non-substitution and non-adherence in genetics, and these are the factors which need to for the future discussion as well. Patients, as far as possible, should be maintained in a single formulation. And if we decide to convert, then the conversion must be followed up by maintenance, at least 3 blood levels over time, to make sure that their exposure doesn't change. And with that, I say thank you very much.